is Bombay, and I'm just going to dedicate one slide, a quick look, guys. Let's quickly practice opportunistic infections in AIDS positive patients. Every time if he gives you a CD4 count, I think everybody is aware of normal CD4 count. No, that's going to be something in the range of 800 to 1200 cells per cubic millimeter. But if the CD4 count is going to fall, right, the moment it's going to fall to less than 500, that's what is going to come in. That's when it's going to go down to less than 200. That's where pneumocystis girovasi. And today I taught you why do they call it pneumocystis is because of the fact that it can cause multiple small cysts in the lungs. As you can see in this particular X-ray, you can see multiple small cystic cavities. So this organism looks harmless, but at the same time can cause extensive damage in the lungs of the patient. When the count goes down to 100, that is what comes in. The person will start having seizures. So the MCQ will describe a AIDS positive patient having convulsions. And why do you have convulsions in an AIDS positive chap, guys? That would be because of cerebral toxoplasmosis. So definitely opportunistic infections should be known, and they love to ask about it. When it goes down to 50, what's going to happen is, one, this guy will go blind. If this guy will go blind, that is cytomegalovirus retinitis. And second is going to be Mycobacterium avium intercellular. So please remember the fact that he can definitely ask you about these opportunistic infections by giving you clinical history. And he can even ask you two-step question where he will ask you to diagnose. Like what I did was, this was a two-step question. In this two-step question, first you have to diagnose it was girovasi and not TB. And the second step that you have to do in this question was then move on to what are you going to do about it. So let's go here, right? Can you tell me the drug of choice for Mycobacterium avium intercellular? For TB, you all know, right? For MAI, guys, what do you give? And drug of choice is again something they're not going to ask you DOC right away. वो ऐसे नहीं बोलेगा what is the drug of choice for this condition. He'll give you a scenario and then he's going to ask you questions related to what is the treatment for this guy. Drugs have to be rock solid, guys. I mean, you never ever can mess around with drugs question going wrong. I mean, pharmacology, I want you guys to score 80%. If your pharma is good, guys, if you score 80% pharmacology, it will pump up your other subjects also. And obviously medicine is important, surgery is important, so you need to focus on them. For cytomegalovirus retinitis, you very well know the fact we will be giving ganciclovir to the patient. What will you give for toxoplasmosis, guys? I give you two options. Would you give spiramycin or would you give pyrimethamine? The options are spiramycin, pyrimethamine. In OBGY, they teach you spiramycin. But why do they teach you spiramycin in OBGY? Because they want to tell you how to prevent the disease from going from mother to baby. Here, I'm not asking you how are you going to prevent toxoplasmosis from going from mother to baby. Here, I'm asking you how would you treat the case. So please remember the fact that in obstetrics and gynecology, the teacher would tell you that the drug that we are going to use for management of cerebral toxoplasmosis or toxoplasmosis is going to be spiramycin. That's for pregnancy. But in actual clinical practice, when you have a case, you're going to be using pyrimethamine and sulfadoxine combination. For girovasi, both for treatment as well as prophylaxis, you're going to be using cotrimoxazole. And well, when it comes to tuberculosis, guys, you will have to do two things. You will have to start the patient on AIDS treatment, and you will also have to start the patient on anti-tubercular treatment. He has also asked in the exam, which of the two will you start first? I think all of you are aware, do not start with AIDS treatment first, because most doctors are under impression that if you will start on AIDS treatment, what will happen? Immunity will increase. But when immunity will increase, it will cause side effects also, guys. It will result in development of what is called as iris. That is immune reconstitution immunological syndrome. So don't give CART. It will cause high grade fever, chills in the patient. Patient will rather abuse you for causing misery in him. First give ATT, then give combination antiretroviral therapy. The gap is going to be 2 weeks. And he's also going to ask you which drug is not used. So we do not use rifampicin. Why we don't use rifampicin in HIV with AIDS is because rifampicin interacts with which drug? Protease inhibitor. So what are you gonna do? You are gonna not stop protease inhibitors, because if you stop protease inhibitors, it will cause more mutation in the virus. So you're gonna stop rifampicin. And he's also gonna ask you that if you stop rifampicin in the person, then obviously you will lose your firepower, no? If you will lose your firepower, then what are you going to give in place of rifampicin? You are going to give rifabutane. So these are a couple of opportunistic infections which are traditionally asked for AIDS, and I've just mentioned about the drug treatments for each one of these as well. So please remember the fact that when it comes to questions which are relatively longer, it is reading speed that has to be increased, and that will not increase overnight. My open suggestion to you guys is, don't on a regular basis just keep on studying. Do regularly questions on a regular basis, so that you can definitely be able to score better, because practice is what going to make you perfect. It's the time that you spend with your app, the time that you spend with the notes, that's going to enhance your performance, that's going to enhance your productivity. Let's look at the next question, guys. I think that's pretty straightforward. This is a lady, 35 years, female, and she's come with rash with convexities on the face, you can see, and the lesions are worsening with hot drinks and sunlight and emotion. So he says, what is the diagnosis? Now, in these circumstances, if he's going to say what is the diagnosis of this particular case, then uh, a lot of people, they might think in terms of possibilities of one. You see, because there's a rash on the cheeks of the person, right? Rash on the cheeks of the person. So one possibility is it could be SLE. You see, an SLE rash is worsened with sunlight exposure. But the point against it is, you see, SLE rash is present only on the cheeks. The SLE rash is present only on the cheeks, but in this case, you can see rash is involving even the chin of the person. And not only the rash is involving the chin, if I zoom it in, you can also see some pustules. These pustules are present all through. They look like comedones, right? They look like comedones in acne. If you read this question, the impression first that we tend to get is that this is a rash of SLE, but the careful look will tell you that this is not SLE. Why? Because there are some pustules also present. So is it acne? Is it acne? Is it nodular cystic acne? Is it acne rosacea? Well, I'm ruling out option number A because there is no drug given in this question. Option number B definitely could be there, could not be there. That's one possibility. Acne rosacea, yes, could or could not be there. It's definitely not nodulocystic acne because it's not so pronounced. Now, between option number B and C, what is the clinching word? The clinching word is that the rash of the person is worsening on hot drinks and sunlight and emotion. Please remember the fact SLE rash is not worsened with hot drink. SLE rash is not worsened by emotion. Here you can see it is hot drink worsening, it is sunlight, it is emotion. So the correct answer for this particular question would be given by you as acne rosacea. That's where you read about rhinopyma also. No? What is the highlight of acne rosacea? Why is the answer acne rosacea? Is because when you will listen to the RR component of dermatology, or if you have gone through his notes, you will notice that acne rosacea involves the convexities of the face. And what are the convexities of the face? The convexities are going to be like the cheeks or the chin of the person or the forehead of the person. So in this particular case, you will also notice a sparing. Let me just mark out the sparing. There is no involvement around the lips of the person. You can see there is no involvement around the lips of this person, and there is no involvement even around the eyes of this person. I mean, the eyes are not very well developed, but then there is no involvement around the eyes of this person. So another feature of acne rosacea, which is very characteristic, is that there is sparing. Now, what is spared in acne rosacea? It is perioral, and second is gonna be around the eyes of the patient. So periocular is what I can write here before you. The third feature, which is again a very characteristic feature, is that the worsening of this particular rash is occurring not only on sunlight. If it was only sunlight, I could have thought about SLE, but because it is going to be worsened even with emotion, it's going to be worsened even with hot drinks. So I'm going to give a more accurate answer here, that is acne rosacea. Guys, a similar question of this kind has been asked in previous year's exam, not this August one, but then a lot of guys, they thought it is SLE by using word sunlight. My request to you is, when you read a question, don't focus only on one word, but look at the entire perspective of the question given. The answer to this question is option number C. Let's move to the next one, which is somewhat similar to the one that was asked in this time's exam. You can see a huge gross ascites. I mean, the moment even before you start reading this exam, you can see the gross ascites present. You can see the everted umbilicus of the patient. So by looking at the everted umbilicus, one possibility is this patient is pregnant. No? That's one possibility. But second, if you look at the everted umbilicus, that normally does not happen in pregnancy. And then he's also shown some tumor mass also. Let's read the question quickly. This is a 50-year-old postmenopausal lady who's having abdominal distension with developmental cachexia. Whenever you read the word cachexia, what should strike you? You always have to think in terms of malignancy. Because cachexia is gonna be a weight loss like 25 kg weight loss, 25 kg weight loss in, let me say, 2 months, 3 months. So this one favors possibility of a cancer. On abdominal examination, the tummy is all bloated. You can notice fluid thrill. You are all aware fluid thrill usually appears when there's gonna be something in the range of about 500 to 1000 ml of fluid present. And MRI abdomen is showing a tumor originating in the left ovary. So what is my clinical diagnosis, guys? My clinical diagnosis on reading the first 4 line of the MCQ is that this lady is having a query malignant ascites. Why I'm saying malignant ascites? Because you can very well see in this question, one problem is there definitely are evidence of tumor. He has himself given that. And he's telling you that there is free fluid in the abdomen. No, he has himself written free fluid in the abdomen. So majority of information is given in the first 5 lines of the question. He's simply asking you that malignant ascites is due to ovarian cancer, carcinoma ovary. What he's asking you is, in this particular question, how does it spread? You see, option A says direct spread. Direct spread is what you read in Hodgkin's lymphoma, no, where the cancer will go from one lymph node to another. So Hodgkin's lymphoma is an example of a direct spread or a lymphatic spread. B says transcoelomic spread, that is spread via the coelomic cavity, that is the peritoneal cavity. So okay, maybe the answer. Let's read further. Lymphatic dissemination. Lymphatic dissemination is again valid for, like, seminoma or for Hodgkin's lymphoma. You can rule out 2 options in this question very easily. Direct implantation, I mean, there's something directly touching. No. Lymphatic dissemination, definitely not. In fact, a lot of people in the actual exam tended to answer as lymphatic dissemination. But please remember, if you compare between option B and D here, hematogenous dissemination is what you read for cancers like non-Hodgkin's lymphoma. Hematogenous dissemination is what you read for follicular cancer of thyroid. They are the ones which are gonna metastasize via the bloodstream. But in this particular question, guys, malignant ascites, I mean, this is a question of OBGY/medicine interrolled into one. In a case of malignant ascites, what is the method of spread? The correct answer for this would be given as transcoelomic spread. The question could have been a one-liner also. Na? If he had simply put that in person, what is the number one? I mean, in previous, what he used to do. In previous years, he used to ask, what is the cause of malignant ascites? What is the cause of malignant pleural effusion? The number one cause for malignant ascites is ovarian cancer. And then step 2 would be that if a person is having a malignant ascites, why is it happening? So that's not a direct contact. It is not a lymphatic dissemination. We tend to call it a transcoelomic spread of the cancer cells, which will irritate the peritoneum. And the irritation of the peritoneum will contribute to a peritoneal fluid accumulation. So that's a substantial fluid present in the tummy of this lady, contributing to development of a fluid thrill. So just a simple concept that you need to remember is he's simply wasting your time in this question. He's wasting your time in this question by writing so much of data. The concept is simply that if you focus on words cachexia, it is a cancer. If it's focused on the word fluid thrill and free fluid in the abdomen, it is going to be a ascitic fluid, which is probably cancerous in origin. Now, where is it coming from? He has himself told you it is an ovarian tissue. He's shown you a big ovarian tumor as well. You are very well aware, no, the commonest cancer of ovary would be a serous cyst adenocarcinoma, not a serous cyst adenoma. A serous cyst adenocarcinoma would be a malignant cancer that can contribute to manifestations like these. Just a general question, guys. Since most of you have answered this correctly, please try and fastest finger, please. What is the number one cause of malignant pleural effusion? Yes, guys, waiting from an answer from you guys. What is the leading cause of, like, a patient has come with a malignant pleural, a person has come with a malignant pleural effusion. Somebody answered pancreatic cancer. No, doc, not a hematogenous one. This was, as I explained to you, it's a transcoelomic spread. Yes, guys, waiting from an answer from you guys. Very good, guys. Somebody's answered very nicely. The number one cause for development of a malignant pleural effusion would be lung cancer. As I mean, obviously, lung cancer. And which lung cancer, central or peripheral? So this doctor has answered beautifully. I could not pick up your name because your mobile phone number was coming up, doctor, but very good answer. The basic concept is, guys, pleura is present peripherally. Because pleura is going to be peripherally located. What's going to happen is that it's going to irritate. I'll put it like this. Suppose this is the representation of the lung. right? And this is going to be a cancer. Then this cancer is going to irritate the pleural surfaces. It's going to irritate the visceral and the parietal pleura, and therefore there's going to be a malignant ascites, malignant pleural effusion developing in a person. So the number one cause for malignant pleural effusion is adenocarcinoma of the lung. For malignant ascites is going to be an ovarian cancer. And well, you could just simply crack this question by looking at a ovarian tumor, and you just need to see how ovarian tumor spreads. And homework for you guys is, I'm not going into the discussion, staging of ovarian cancer to be practiced today. You should have the capacity to write the entire staging in 2 minutes flat. I'll give you rather, I'll say 1.5 minutes. Just try to draw a diagram, read the staging of ovarian cancer, guys, and then just try make a diagram, right, regarding the spread part of it, and the staging part can definitely be asked. I mean, if he can ask you vulval cancer in your exam, right? He asked you vulval cancer, right? If he can ask you vulvar cancer in your exam, he can definitely ask you about ovarian cancer. Let's move on to the next one, guys. A quick read. This is a lady who's having breathlessness for 1 year. Earlier, the breathlessness was on climbing stairs, but now is present on even going to the bathroom. So you can understand that this lady is having dyspnea grade 3. Dyspnea grade 3 would mean on minimal activity. What I mean by minimal activity would be like going to the bathroom, no changing clothes, going to the bathroom. That is grade 3 dyspnea. So she has deteriorated. The workup of the patient is showing bilateral enlarged lymph nodes. You look at the x-ray of this lady, you can definitely see very classical shadows of lymph nodes present. So whenever you're going to read about gender being female, you're going to read about dyspnea on exertion, and you're going to read about bilateral hilar lymphadenopathy, the first thing that should strike your mind in every internal medicine question where you read about bilateral hilar lymphadenopathy in a woman having breathlessness on exertion is sarcoidosis. The question is, however, not asking about sarcoidosis. He's going a step ahead. He's saying that the same lady has now developed these painful blue nodules on her legs. You can see the arrows that are put, the blue lesions on the legs. So he's asking you, what is the lesion present? If you look at option number A of this MCQ, erythema marginatum, you can rule that out. Why? Because marginatum would be what you read with rheumatic fever. You can rule out option number B because erythema migrans is something that you're going to read with Lyme's disease, right? Borrelia. You are left between erythema multiforme and erythema nodosum. When you look at erythema multiforme, guys, it is mainly seen with viral infections like HSV, no? Erythema multiforme will also be having a target sign present, whereas in this condition, you're not having any target sign. Point number one, why erythema multiforme is not the answer is because erythema multiforme should be causing or is seen with viral infections. Number two, it should be having a target lesion, and you cannot see any target lesion. Rather, what you're seeing here is a description he has himself given: purplish, painful nodules. These purplish painful nodules are the ones which are referred to as erythema nodosum. So the correct answer to this particular discussion that I'm doing with you is the overlap of internal medicine and dermatology. You see, guys, the objective of why am I conducting this discussion is to tell you that your mind has to jump from one subject to another. That is the capability that they want you to have. The basic objective of this discussion is to tell you that interlinking of subjects is what you should be capable of. If you can interlink the subjects, you will definitely be able to get 200 plus. I assure you. You see, all of you guys are so intelligent that even if you stop reading today, even then you will get 130, 140. 130, 140 is no big deal in this exam. I highlight this fact. Getting 130, 140 is no big deal in this exam, but getting 150 is big deal, guys, because most guys, they get fatigued. When you have to sit for 2.5 hours, you have to sit for 2.5 hours. You see, you guys are tired already. I discussed 4 MCQs and you might be fidgeting around in your concentration, might be wavering, and you might be checking your WhatsApp and Facebook and what else. You see, our mind tends to wander away. It's like a little baby. Your mind is a little baby. It will wander away. You have to call it back. Aja beta, aja, aja. Come back, focus, focus. And then not only you are supposed to make your mind, which is a little baby going running away, you need to make it focus. You also need to let that mind practice multiple subjects so that your mind can jump from topic A to topic B. For guys sitting here, if you play cricket, you can understand better what I'm saying. If you're playing cricket, guys, the fast bowler can be delivering maybe a toe crusher, he could be delivering a toe crusher Yorker It can be a bouncer. You can't predict now whether the bowler will deliver a Yorker to you that will crush your toe, or he will deliver a bouncer to you that will break your head. So you need to be making the decision at the last moment. Na? When the bowler will deliver the ball, when the ball hits the pitch, your eyes are focused on the ball. That is when you make a decision. Are you gonna go on your back foot, or are you gonna go on your front foot? So just like, I think, I mean, cricket is something that is passion in India, religion in India. So I think most of the guys sitting here can relate to what I'm saying. Whether you're gonna go on a front foot or a back foot while playing cricket is something that you make at the last moment. Similarly, in this exam, guys, your brain has to continuously anticipate what the examiner is throwing at you. It could be a short pitch delivery, a bouncer. It could be a toe crushing delivery, a Yorker. You need to take a decision right at the last moment. So that requires a regular amount of practice. If you do questions, if you do sleep deprivation, now is the time for sleep deprivation. Don't do sleep deprivation next month, November, last week. Most people have a tendency to study more towards the end of the exam. Don't study more towards the end of the exam. Study now. This is the time. This is festival time. Everybody is going out, everybody is enjoying, and I know you will be distracted by social media. Avoid that, guys. My humble request to you, if you're putting an effort to come here and listen to me, get off this damn social media, sacrifice it for 1 month, make this 1 month count, guys. Give it the best you got, give it the best firepower that you have. Show me some attitude, guys. I mean, show me that fire in the belly that you guys are having, and that would be reflected in your final scores. You would definitely get 180 200 marks, definitely a possibility. But the only if is that, do you have that mental aggression what takes to be a doctor? That mental aggression is going to differentiate you from those ordinary people on the road. You are a medical graduate, started right in the beginning, man. Being a doctor is not a joke. Not everybody can be a doctor. It is only a positive attitude. It's always a desire to learn more, and most importantly, realizing what are your weaknesses. So if whatever subject is your weakness, guys, try to focus on that also. Let's handle another one. I mean, coronavirus is the in thing nowadays. It has a trans-species transmission. You very well know that. He's asking you regarding the physical shape of the nucleic acid present in this RNA virion. He's himself told you it is a RNA virion, right? The small RNA virus is mutating, can mutate. I mean, this is causing so much of trouble. And he's asking you regarding the fact that, well, what is the variety? So if you look at the data, I think I'm having correct answers from most of the people. This would be a single-stranded virus, and this is going to be a positive sense enveloped virus. So this is pretty straightforward, guys, pretty an easy one. And let's look at option number D of the same question. If you focus on option number D of the same question, it says SS/DS, circular envelope virus. Expecting answers in the chat box once again, guys. Can you tell me which virus do you read as SS/DS? The question is from virology. You can call it integrated again with medicine, with microbiology, which is SS/DS. Yes, guys. No, Dr. Hitesh, it's going to be A for this particular question. Which virus is SS/DS? What do you mean by SS/DS, guys? SS/DS is partially single-stranded and partially double-stranded virus. You see, the basic issue is normally viruses are either single-stranded or they're double-stranded. Okay, I'm having good answers now. Partially single-stranded and partially double-stranded virus is gonna be Hep B, that is hepatitis B. So good, guys, you're getting a hang of the subject that I'm talking about. When you look at hepatitis B, no, doc, it's not rotavirus. Rotavirus has a circular DNA, right? It is hepatitis B, which is partially single-stranded, partially double-stranded. Why I'm saying that is because in microbiology notes, the microbiologist has told you it is a double-stranded virus. Perfectly right. No issues with that. But what I want you to understand is that in Harrison, the textbook of internal medicine, hepatitis B is written as partially single-stranded, partially double-stranded virus. So please remember this fact in the exam. If you have to select between, double-stranded versus SS/DS, this is what you will mark for Hep B. And for coronavirus, it's obviously a single-strand positive sense enveloped virus, and we are having a tough time handling this small chap. Moving to the next one, overlap from waiting for answers here. The question is asking you regarding which is gonna be the shortest and the least dilatable part of the urethra, right? The shortest and the least dilatable part of the urethra. So a quick diagram here before you guys. Can you tell me the narrowest part of the urethra, by the way? You can take this to be the glans penis, right? The shaft of the penis. Okay. So meanwhile, while the answers are flashing, I'll just highlight some of the core aspects which I have just shown here before you. Guys, what I have shown here before you, this is the prostate, right? This is the tissue of the prostate. So I am going to call this as prostatic urethra. So the diagram that I drawn before you, this is the prostatic urethra. Then what I've shown before you is the shortest and the least dilatable part. The shortest and the least dilatable part of the urethra is called as the membranous urethra. Then is going to be the penile urethra. Then is going to be slight dilatation. This dilatation is the one that is technically called as navicular fossa. And then the question that I put up, please appreciate my two statements. One is what I have asked you is shortest and the least dilatable part of the urethra. A lot of people mess this up with the alternative MCQ. What is the narrowest part of the urethra? You see, I'm jumping from one topic to another because that is what they want to do in the exam. Make your brain jump from topic A to topic B. You can call this surgery, you can call it anatomy, whatever you want to call it, but you should have the capability to move from topic A to topic B. That is flexibility that you need to have. As I gave you an example, like a bowler is delivering a fast ball at you, so you should be able to, adjust your posture. The narrowest part of the urethra is external meatus. The narrowest part of the urethra is external meatus. But if he says what is the shortest and the least dilatable part of the urethra, then it's going to be what is highlighted here. That is the membranous urethra. You can see that when you as doctors will be putting Foley's catheter in a guy, if you will put a disproportionate size Foley's catheter in a individual, you can traumatize the membranous urethra. So lots of time in your residencies, when you guys are, putting a Foley's catheter, there's a distinct possibility of you causing trauma to the membranous urethra. That is where maximum trauma can occur. In contrast, they can also give you a surface marking. Like I have shown this gland here, no, this green color gland. Can you tell me the name of this gland, guys? And this gland is opening in the penile urethra. It is present in the area of the membranous urethra. It's present in the pelvic diaphragm, but this gland is opening in the penile urethra. The gland would be called as Cowper's gland. So lots of time in the exam, what they basically do is they just trouble you with some basic allied aspects. So whenever you're learning anatomy, try to draw a hand diagram by yourself and try to label the data. Like they've just put an image-based question related to veruminatum. Veruminatum is in the prostatic urethra. The clinical information that you need to understand from this particular diagram that I made is that during Foley's catheterization, there is a distinct possibility that if a doctor is putting a disproportionate size Foley's catheter, the part of the urethra that can be ruptured is the membranous urethra. If you inflate the balloon at this area, you would not even push the catheter properly in the bladder, and you try to deploy the balloon air, this is going to pop off, and that's definitely going to be disastrous for the person, from every perspective. I mean, his personal life is going to be messed subsequently, so you should anyway be aware of it. And I can squeeze in one more question here. I taught you narrowest part of the urethra is the external meatus. Shortest and the least dilatable part is the membranous urethra, as I mentioned before you. I just squeeze in one more question quickly. What is the narrowest part of the ureter? Yes, guys, waiting for answer in the chat box. Quickly, guys, what is the narrowest part of the ureter? The narrowest part of the ureter, a couple of flashes. Let me just check. Okay. The narrowest part of the ureter, pelvi-ureteric junction, intramural. No, doc. The narrowest part of the ureter is where the ureter enters into the bladder. The narrowest part. No, Doctor Pelvo. Somebody answered PUJ. No, doc. PUJ is fairly big. No, pelvi-ureteric junction is gonna be big, man, because PU. No, not uretropelvic. There's no term like uretro. Trigone. Doc. Trigone is urinary bladder. I am asking you narrowest part of the ureter. The narrowest part of the ureter is where the ureter enters into the bladder. You see, if you study the anatomy, no, doc, there's no term like dome of the bladder. The narrowest part of the ureter is vesico-ureteric junction. You see, I'll just draw it like if this is urinary bladder, no, the ureter tends to go on the back side. It tends to go on the back side of the urinary bladder. The ureter tends to go on the back side of the ureter, and then it opens into the urinary bladder. So do study the anatomy of ureter very thoroughly. We study abdomen very nicely. All of us study abdomen very nicely. Pelvis nahi aata, head and neck nahi aata. So head and neck anatomy is where people get screwed up. Pelvis is where people get screwed up. Upper limb, lower limb, everybody knows. No, he's not going to ask you upper limb, lower limb. Very easy questions, upper limb, lower limb. Nobody gets affected, guys. It is vesico-ureteric junction. In the diagram, I try to show if this is UB, this is urinary bladder, then the ureter goes on the back side of the bladder, and that is where it enters, and that is where the stone can get impacted. Now tell me, what will you do for the treatment of the stone, guys? Suppose I'm putting a red mark here. Suppose there's a stone stuck here. How would you remove this ureteric stone? What is the treatment for ureteric stone impacted at the vesico-ureteric junction? What can you do? Okay, we will be doing a uretro. Okay, you did not type it properly. E, no, it's not ECWL, buddy. It's ESWR. Uretroscopy, PCNL. No, 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 no. Yes, that is uretroscopic retrieval. That uretroscopic retrieval would be you will go like this. No, if this is the urethra, so you are gonna go retrogradely like this. You're gonna send in the camera, send in the camera, send in the camera, and then what are you gonna do? You are gonna deploy a basket here, and that basket will trap the stone, and you will remove it. So the procedure will be a uretroscopic retrieval, as somebody said very rightly. And what you do is you deploy a Dormia basket. So guys, what I am trying to tell you is it's not simply the fact that I am trying to deal with only anatomy. What I'm trying to tell you is that at least, two clinical domains that I've tried to highlight here before you is one, that if a doctor is deploying the Foley's catheter wrongly, he can rupture the membranous urethra. Point number two is how do you retrieve a ureteric stone? It's not PCNL. It's not going to be answered as ESWL, buddy. It's going to be a uretroscopic retrograde. Yes, it's going to be retrograde uretroscopic procedure where we deploy a Dormia basket and we're going to remove the stone in one place. So please read pelvis very, very thoroughly. Please read. In surgery, my advice to you is don't start surgery from achalasia cardia. Majority of guys, what they do is they read achalasia cardia, they read stomach, small intestine, and they feel that, okay, systemic GI surgery is over. Buddy, if you are going to start from, stomach and achalasia cardia and do small intestine, that everybody does, and very limited questions are there. Read retrogradely, read from rectum cancer, read anal cancer, read prostatic cancer, testicular cancer, penile cancer. It is retrograde, guys, that they are asking now. So you have to get into the psyche of the examiner, because the psyche of the examiner would definitely let you know that, you have to be like a psychologist. Like you are a patient, you are sitting with a patient, and he's telling you some crap. So you analyze his brain. Similarly, think what the examiner is trying to analyze before you or ask you, and then try to answer. Let's do one more, guys. This is about this 35-year-old lady. She's having weakness in the both legs, leading to inability to stand for 2 days. So there's definitely something wrong with her nervous system. Now, when you read knee jerk and ankle jerk are absent, whenever you read knee jerk and ankle jerk are absent, it tells you it could be a lower motor neuron lesion. That tells you it could be lesion in the spinal cord. The power is also reduced in this case. There's a hypotonia. So there are 2 points in favor of lower motor neuron lesion. One is hypotonia because it's saying power of 1/5. Second is absent reflexes. So he's himself telling you that there is something related to the spinal cord. There is no sensory deficit, bladder and control is present, and Skiros media was used for etiology presentation. So what is the presentation, guys? This lady is having flaccid. I'm writing flaccid because it is lower motor neuron lesion. This lady is having flaccid paraplegia. Which disease has flaccid paraplegia? You all know, Guillain-Barré syndrome. In Guillain-Barré syndrome, what is the etiological organism that has been asked? You need to apply microbiology here. This is an overlap between medicine and microbiology. He has given you Skiros media. I think all of you are aware of the fact that Skiros media is used to isolate which organism, which is the trigger for Guillain-Barré syndrome. Yes, most of you guessed it right, and that's going to be answered as Campylobacter jejuni. So, well, that was good. Campylobacter jejuni is the organism responsible. So, straightforward answer. And suppose, let me say hypothetically, you were not able to work out this information of Skiros media. Like in the exam, you say, sir, there is so many things. How do you expect me to remember so many things? You say, sir, there is so much a subject, 19 subjects. You expect me to remember everything? You have been practicing. I have not been practicing for so long. So I will say then do exclusion. How will you do exclusion? Listeria. Listeria causes neonatal meningitis. So that is why it is ruled out, because you don't read listeria causing any kind of paralysis in anybody. When it comes to bordetella pertussis, it causes 100-day cough. No, it causes pertussis. And what does brucella cause? Brucella causes undulant fever. You can easily rule out option A, B, C of the MCQ by exclusion right away, by simply focusing on the aspects that I said. So even if you are not aware of the Skiros media fact, even if you're not aware of, per se the term Guillain-Barré syndrome, you can just solve this question by the fact that because brucella causes undulant fever, no fever given. There is no cough given in the question. There is no neonate being mentioned here. So by exclusion also, you can still work out the answer to this question. So don't leave any questions in the exam. Attempt all questions in the exam. And again, I'm saying a lot of you tend to leave some questions for marking later. When you will mark them later, what happens is that you hardly have time. So judiciously utilize your time to do questions on a regular basis. You have to minimize the questions left behind for marking. I personally would not advise more than 10 to 15 questions in both the papers combined to be left for marking. Rest all questions have to be attempted with the maximum knowledge that you have, and try to use exclusion skills. Piece of cake, this question, we are talking about a burn patient. This patient is having burn on the legs due to blast of a cooking stove for last 1 week, and now she's having fever, chills, rigors. Heart rate is more, BP is, so there's definitely a infection, there's definitely a sepsis, and the person or this lady is going into septic shock. Now you are very well aware of the fact that in a burns case, what is going to be a leading cause of sepsis or septic shock? Either it's going to be pseudomonas, or if it's not going to be pseudomonas, it is going to be staph aureus that would be coming from the hospital environment. So there's only two possibilities in the question. On a comparison basis, you very well know the fact that pseudomonas is the leading one. So all you need to do in this particular question is identify pseudomonas. You see option A, I'm ruling out gram-positive cocci in clusters, that is staph aureus. I'm ruling out option number B, gram-positive cocci in chains, because that's going to be streptococcus. If you look at C and D, that's where the answer is, right? Gram-negative rod, you all know, and pseudomonas is a motile bacteria. Now this motile bacteria would be having a single polar flagellum. You are ruling out option number C. The correct answer to this question is option number delta, gram-negative rod, motile with a single polar flagellum. And that's a piece of cake, guys, because septic shock always will be having pseudomonas. Let's take this question forward. Tell me the best drug for treatment of this lady. She's having burns on her legs, pretty substantial. What antibiotic would you start for this lady? Because there's a possibility he may not ask you only about pseudomonas. No, these questions are at the moment simpler because I just wanted to get your attention. Because if I straight away start with the difficult ones, people tend to get bogged down. So I want you to get them right, because guys, MCI exam is a screening exam. Majority of the questions that are asked are very simple and straightforward. It is only that with the width of the question they're bothering you. Otherwise, all of you, I said, are intelligent enough to get these marks, right, guys? It would be Piptaz is the correct answer. What we will be doing in this case would be starting the patient on piperacillin. If you have to give a single best answer for treatment of pseudomonas, it is piperacillin. Another antibiotic that can be used here is tazobactam. So piperacillin, tazobactam are the usual molecules that we use for management. No, doctor, not silver nitrate. I mean, silver nitrate is only gonna prevent colonization. But see, in this question, she's already had a colonization of the wound. No, she's already 8 days in the hospital. Because the patient is vancomycin, buddy, is for staph aureus. Vanco is for staph aureus. No, I asked you for pseudomonas. For pseudomonas, what are you going to give? You're not going to answer a third generation cephalosporin. You're going to give a piperacillin and a tazobactam combination. Answer to this question is option number delta. And I'll just dedicate one more slide, because everybody was talking about and people started commenting about staph aureus and azithromycin, stuff like that also. So please appreciate that staph aureus is usually an important cause of surgical site infections. Where does it come from? The surgical site infection will come from the nares of the doctor or the nurse. You see, a lot of us might be having lot of hair in our nasal cavity. Nares of a doctor or of a nurse would be harboring staph aureus, and therefore, if a doctor or nurse will not put on a mask properly, then this bacteria will fall on the surgical site and will cause a surgical site infection. In the previous years in the exam, they said, what is the treatment for staph aureus in a doctor or nurse who's having colonization of the nares? I repeat my statement. The question in the previous years was, a doctor or nurse is having colonization of the nares So what will you give to the doctor or the nurse so that you can handle the colonization? You will be applying a topical cream here. The topical cream would be mupirocin. Please appreciate the fact that if a doctor or nurse is having colonization with Staph aureus, you ideally should not be allowed in the OT. In fact, the person should be banned from the operation theater duty till he's clear. But if a person will develop infection, then for Staph aureus, because most of the time the stains are MRSA, we'll obviously give vancomycin. If it is VRSA, we will be using daptomycin in the patient. So these are the antibiotics that you would use for Staph aureus, man. But what I asked you was for Pseudomonas. Nasty chap, no? Pseudomonas aeruginosa. Can you tell me the culture media for Pseudomonas aeruginosa, guys? You have today in a hospital taken a pus swab. You've taken a swab of pus from a burns patient in your ward. You are transferring it to micro department. The microbiology resident will plate it on which culture media? Yes, guys. Okay, good answers. That would be cetrimide agar. Do remember the fact that Pseudomonas is a nasty chap. It grows on cetrimide. And once this report will come, you are gonna start the patient on piptaz. That's gonna be piperacillin right away. So if you are gonna have Pseudomonas aeruginosa, it's piperacillin. And another clinical scenario they can give you for Pseudomonas is for ventilator-associated pneumonia. I hope everybody is aware the number one cause for VAP, ventilator-associated pneumonia. So he can talk about a chap on ventilator and he's been there on 2-3 days. Like, COVID-19 pneumonia patient was intubated. A lot of our COVID-19 patients who are intubated are not dying because of COVID-19. They're dying because of the tubes of the ventilator not sterilized properly. So they're colonized by Staph aureus or by Pseudomonas, and therefore the patient can develop Pseudomonas or a Staph aureus pneumonia. So for leading cause for VAP and obviously in burns patient is Pseudomonas. So that's obviously something that you're aware of. Let's do a next one quickly, guys. If you are having a chap ingesting larvae in undercooked pork, we are obviously talking about Taenia solium, right? So what will the person develop? He has consumed undercooked pork. He's ingesting larva. The word is larva. So what will the person develop? And is a question again from the previous years. Quickly, guys, fast fingers. All of the above. No, no, not neurocysticercosis. No, cysticercosis. No. So I'm having jumps, right? Okay. Now are coming the correct answers. So I had a varied response. Please appreciate, guys. Listen to my words carefully. People who have answered A or B are not correct. Why? Because if a person is consuming, and listen to my words carefully, if a person is gonna consume vegetables which are grown on fecally contaminated soil, then this person is gonna end up with ingestion of eggs. When a person will ingest eggs related to Taenia solium, these eggs will go in the GI tract. From the GI tract, they will be absorbed into the blood circulation. And from the blood circulation, it will go to the brain, contributing to neurocysticercosis, and to the skeletal muscles, contributing to cysticercosis. Please appreciate the fact for neurocysticercosis, that is option number B, and cysticercosis, that is skeletal muscle involvement, that is option number A. The person should be ingesting eggs. But what did he ask in the exam? He did not ask ingestion of the eggs. He said ingestion of the larvae. The moment the person will ingest the larvae, what will happen? They will go in the intestine and they will hatch into adult tapeworms. The person will develop intestinal tapeworms. These are the kind of questions that can definitely cause silly mistakes. So those who got right, great. But otherwise, guys, a lot of time we tend to mess up on the fact because no, doctor, starry sky appearance in neurocysticercosis is when the person is ingesting eggs. That's the point that I'm trying to highlight. What you need to understand here is the fact that if a chap is going to be consuming eggs, that is when that brain manifestation occurs. If it is going to be only larvae getting ingested, in those circumstances, it's only exclusively gonna cause development of intestinal tapeworms. Yes, guys, treatment for cysticercosis would be what? For neurocysticercosis, we give albendazole. For the seizures component, in this case, we will be giving carbamazepine. So for patients who are having neurocysticercosis, we give steroids. Why we give steroids? Cerebral edema, because there's swelling around the where the worms are present. We give albendazole to kill the worm, and for controlling the focal seizure, I think everybody knows in neurocysticercosis we have focal seizures, so we will be giving carbamazepine for the person for at least 2 years. After 2 years, you can discontinue. What will you give for treatment of cysticercosis? Your answer would be given as praziquantel. If he says, what will you give for treatment of intestinal tapeworms? Your answer would still be praziquantel. So albendazole is only to be answered or asked or answered primarily when he will ask you about neurocysticercosis. Pretty straightforward information and definitely can be worked out. If he says, what is the first test for neurocysticercosis? Yes, guys, is it a CT or MRI? Question to you guys, waiting for fast answer. CT, MRI, which is the first best imaging investigation? Okay, had CT, MRI, CT, MRI fight going on. Okay, let us resolve this, right? CT is not the correct answer. Is not the correct answer. CT is not the correct answer. 50% people got this wrong. Why? Sir, CT can pick up calcification. You yourself tell me, is calcification a early feature or a late feature? Somebody is answering contrast enhanced CT also. Please tell me, CT will pick up calcification, good, but in neurocysticercosis, calcification will occur. Calcification is not a early feature, na? Calcification is a late feature. CT scan will pick up calcification after 6 months. I need a diagnosis right now. So therefore, if they ask you in the exam, what is the best way for diagnosis of neurocysticercosis imaging perspective? Your answer is going to be MRI. And I'll add to that, you should answer contrast enhanced MRI. Why contrast enhanced MRI? Because you want to demonstrate the damage to the blood-brain barrier. You want to demonstrate the cerebral edema component, because wherever the larva are developing, the eggs will hatch in the larva. You need to demonstrate the presentation of cerebral edema in the person. So if they ask you what is the imaging modality for the person, the imaging modality is not a CT scan, because CT will pick up picture late. I want a early diagnosis. It is a contrast enhanced MRI, which would be done in this case to identify cerebral edema. Okay, next question. What is the best drug for management of cerebral edema? Waiting for answers. How would you manage cerebral edema? I mean, best drug for vasogenic cerebral edema. There is damage to the blood vessels of the brain, no? By the inflammation. So what would you use? Mannitol. No, mannitol is not the answer. Mannitol is not the answer. Steroids is the correct answer. I said it, man. I said it. Steroids are given for cerebral edema. No, Dr. Furosemide is used for heart failure. It is steroids for vasogenic cerebral edema. Please appreciate, guys, that there's one hell of a difference between raised ICT and vasogenic cerebral edema. Raised ICT is what you get in head injury and in brain tumor. For brain tumor is pressing on the ventricles of the brain. Head injury is pressing on the ventricles of the brain. For treatment of raised ICP, if I was asking you, doctor, what are you gonna give for raised ICP? Mannitol is the correct answer, no issues. But what did I ask you? I asked you vasogenic cerebral edema. Guys, please appreciate the fact there's damage to the blood-brain barrier, this damage to the blood vessels, which are the foot. I mean, what is blood-brain barrier composed of, right? That is foot processes of astrocytes. You need to prevent further damage. To prevent further damage, what are you gonna use? You're gonna use steroids. In this case, it is dexamethasone that is used. Please read about cysticercosis, guys. It's an important infection that is asked. Let's move on to the next one. This question is talking about the 65-year-old chap. He's having fever with chills for last 1 week. So the doctor did testing for COVID-19, typhoid, malaria, dengue. I mean, common infections, right? The common infections are negative. The past medical history is telling you that this chap is having aortic valve calcification and he had undergone an aortic valve replacement. The moment you read that, you know that anybody who's having fever and is having history of valvular heart disease, who's having history of valvular replacement, the clinical diagnosis of this guy is query infective endocarditis. The clinical diagnosis of this guy is query prostatic valve endocarditis, because he has himself told that patient had undergone aortic valve replacement. So that means he has undergone a procedural replacement of the valve, right? So it is a prostatic valve endocarditis. Let me just check out the answers, the various answers coming up here. B, C, okay. Let's work it out, right? Okay, now people are getting more into the rhythm. Guys, the basic point is in prostatic valve endocarditis, infection can occur in the first 2 months. It can occur anytime between 2 to 12 months. It can occur anytime after 12 months. So we have an early onset or an intermediate onset or a late onset. For early onset, the answer is cons, coagulous negative staphylococcus. But see, he has given you the year in 2019, now is 2020. So we're assuming at least 1 year has gone by. Between 2 to 12 months, the organism responsible is Streptococcus viridans. Yes, the same organism that causes SAB is the villain in person having prosthetic valve endocarditis. So this was again a two-step question in which first you had to analyze that the person is having an infection in the heart. Step number 2 was to identify which infection is occurring in the person. That's going to be late onset endocarditis because it's almost 1 year happening now. So the correct answer for this question would be option number C. And well, anyway, not Staph aureus, guys, that we study with acute bacterial endocarditis or with right-sided endocarditis. Enterococcus is mainly related to left-sided endocarditis. Somebody is having a left-sided endocarditis, then it is enterococcus which is to be considered, one of the organisms. The answer to this one is beta. Let's move on. A very straightforward one. They just gave an image like this. They are talking about an unimmunized child. No, so whenever they ask about unimmunized child in India, there are two possibilities always to be considered. One is TB, and second is the diagnosis of this case. You can see this girl. She's having fever, sore throat, difficulty in breathing, and a membrane is noted in the throat. So you very well know the clinical diagnosis is diphtheria. I'll just zoom in the image. You can see this uh, membrane, whitish grayish membrane, which is present in the pharyngeal wall of the person. So for diagnosis of this case, you very well know. I mean, you don't need to even look at the options now. In this question, you're hunting for options, man. Most of the time in clinical practice, what we do is within 1 day diagnosis can be obtained by taking a swab and putting it on Loeffler serum slope. All of you are aware that microbiologists would have taught you about the Schick's test. We don't do a Schick's test anymore for diphtheria. We use a Loeffler serum slope. Within 6 to 8 hours, diagnosis is there. Or you can plate the colonies on the answer to this question. That's going to be potassium telluride. You can obviously rule out the options. Otherwise, Robertson cooked meat broth is for anaerobic organisms, so obviously can be ruled out. Ludlam's media, something that you read with Staph aureus, so can be ruled out. Pike's media is what you read with Streptococcus, so that can be ruled out. So guys, it's been years that I have read microbiology, but even today I'm remembering it because I have handled cases, I've seen patients. A lot of you have gone abroad, in some countries, clinical exposure is not there. So there it is all the way more important that you listen more and more. If you've seen cases, great, because diphtheria is very common in developing countries. And what I was saying initially was unimmunized. Whenever a question begins with unimmunized child, most of the time the question is either about TB, or it's gonna be about diphtheria, or it's gonna be either regarding measles. Most of the time in Indian exams, no, because these are the usual presentations that you get at primary health center, and therefore you are spot on to identify it. I think everybody knows that diphtheria is a toxinemia. It is a toxin mediated disease. There is no bacteremia. There is no bacteremia. It is a toxin mediated disease, and diphtheria can cause death also. Can you tell me the cause of death in diphtheria, guys? I give you options: respiratory tract infection, myocarditis, orchitis, aseptic meningitis. Why would a patient of diphtheria die? Is it laryngeal diphtheria? Is it myocarditis? Yes, it is myocarditis, which is the leading cause of death. The toxin will affect the heart. So it is not the respiratory tract obstruction. Majority of people tend to answer it as respiratory tract obstruction, but this is myocarditis, which contributes to death in a case of diphtheria. For treatment, we'll have to use either we can use azithromycin or erythromycin, either of the two, or we can use penicillin. Let's move on to another one, a quick one from pediatrics, slightly a longish one. So let's read it quickly. Let's think this is an exam. Let's think it's like a 45-second, 1-minute MCQ. Let's focus on the screen and work out the information provided. We are having a 35-year-old primee, so it's a little late for she getting pregnant. So we are talking about maybe an elderly primee. She's short stature. Now short stature can cause birth injury. She's delivered a girl baby in the labor room, and Apgar score is only 5 at 5 minutes. I mean, Apgar score at 5 at 5 minutes basically is a definition of the word birth asphyxia. The bottom line is, I mean, when do you say birth asphyxia? It's not delayed cry, because delayed cry is something which is very subjective. I say baby cried after 30 seconds, you say baby cried after 1 minute, other person is saying baby cried 1.5 minutes. It doesn't mean anything. It is Apgar scoring at 5 or 5 less than 5 at 5 minutes that tells you that there is birth asphyxia, and that is causing seizures. What is the type of seizures that is seen in newborn baby? It is subtle seizure. So this newborn baby after birth is having subtle seizure. The child was kept in the NICU on maintenance IV fluid, phenobarbital. You are all aware that the maintenance fluid of choice in little babies is 10% dextrose. 10% dextrose because baby needs sugar, not normal saline. And phenobarbital is the preferred anti-epileptic drug to be given. The doctor has done the right thing. He is not breastfeeding the baby. The baby is having brisk reflexes, Moro's reflex. That's again because of damage to the brain. Now the problem is because the baby is in NICU, the mother cannot breastfeed the baby. And because she cannot breastfeed the baby, she's having engorged breasts. So the question is saying, what advice would you give her? Let's read A. It says breast pump to relieve the engorgement. Yes, I mean, this looks logical, no? Breast pump to relieve the engorgement. Baby is not well and has developed hypoxic ischemic encephalopathy. Yes, looks like a correct answer. Let's look at B. Use the breast pump to relieve the engorgement. Baby is well and would be discharged next day. Well, the wrong thing is baby is not well. No, a child having seizures cannot be discharged the next day. You can obviously rule out option number C in this case, prescribe painkillers, because we don't give painkillers for engorged breast. You need to relieve the engorgement, not with painkiller, but it is rather the expression of the breast milk. The correct answer can definitely be worked out is option number A. Majority of questions which are relatively longer will have some key points in the question. Only 1 to 2 key points in the question that will make you come to the correct diagnosis and the correct diagnosis. So I mean, most of the questions, guys, as I said, no, like a lot of chaps in first attempt have scored 200 plus. That's because they simply did not think that they were sitting for exam. They were all cool and relaxed. Give so much of test papers nowadays, that when you sit in the exam, no, it becomes a habit for you. Becomes a habit for you that the child, I mean, it's a habit for you to go for an exam. Okay, let's look at the next one. A quick overview. This is a 8-month-old kid having breathing difficulty. He's having fever for 2 days, so okay, could be pneumonia. Respiratory rate is 40 per minute. That's a little faster, right? For 8-month-old baby, that's not a very good value. You're aware from the ARI control program, no? Between 2 to 12 months of age, respiratory rate more than 50 is definitely a cause of concern. I think all of you are aware of, 60, 50, 40 cutoff. So at 8 months, this is definitely a cause of concern. Rhonchi are heard in the chest of this patient on the subscapular and infraaxillary areas. And what is the correct management of this child? He has given you just a part of the X-ray, guys. The bottom line is, what is the diagnosis? The diagnosis of this child is small airway disease. Because there is inflammation of the small airways, the clinical diagnosis of this child is bronchiolitis, and this bronchiolitis would be usually caused by respiratory syncytial virus. If you look at option A, it says possible foreign body aspiration. Now, yeah, I mean, babies can have foreign body aspiration, but that will not contribute to any kind of rhonchi in the chest, and even the X-ray per se does not show any very clear foreign body. The image is little cut out because of the resolution and the bandwidth issues, etc., etc. But the bottom line is, guys, I mean, foreign body is usually more common after 1 year, because at that point of time, foreign body is usually more common at, in fact, 8 months. Why I'm saying, let's look at 8 months. You are all aware of pincer grasp, no? We have a mature pincer grasp, we have an immature pincer grasp. I think everybody is aware that mature pincer grasp develops something by the range of 9 months, immature one. And mature pincer grasp usually develops by 1 year of age. So most of the time, babies will be having foreign body injection at round about this age. In this question, it is given at 8 months of age. Why am I ruling out foreign body is even clinically? Because foreign body, to pick up a foreign body, a baby should definitely be in a position to actually, the little baby should be in the, or should be at least be able to pick up. That's more important, no? Be able to pick up any small object. So in this case, I want you to appreciate the fact that the age group is little on the higher side. So I'm ruling out option number A. Option number B says that this particular kid admit and give nebulization with salbutamol and reassess with pulse oximeter. Now, salbutamol to be given to a child looks okay, but that is for a patient who's having bronchial asthma. To give salbutamol to bronchiolitis, well, does not make too much of sense. I'm ruling out option number B because that would be more valid for children who are having asthma. So I'm ruling out option number B as well. When you look at option number C in this question, option number C of this question says categorically give supplemental oxygen and nebulize ribavirin. You're all aware of the fact that to kill respiratory syncytial virus, we require ribavirin. Let's read D. Antibiotics. Well, if it was pneumonia, why am I ruling out pneumonia is because there is no bronchial breathing in this case. There's no crepitations in the chest. It's rhonchi, and rhonchi at before 1 year of age is bronchiolitis. So the correct answer in this question should be kept as option number C, supplemental oxygen and nebulized ribavirin, because I'm going to kill respiratory syncytial virus. This is again a two-step MCQ where first you have to diagnose what is the problem of the kid and then kill the bad guys. Let's move to the next one. Spot diagnosis, guys. Even without a history, you should be able to pick this up. Okay, what is the diagnosis, guys? Is it measles or is it chickenpox? Rash on the body. Is it measles? Is it chickenpox? Yes, guys, waiting for an answer. You can see macules, you can see papules, and you can see vesicles also. You can see some blisters forming, right? These blisters have ruptured. So what is the diagnosis? This is chickenpox, right? This is not measles. You can see some vesicles, no? I mean, I think you can pick out from the resolution that some of the vesicular lesions present. So what I can see on the body of this baby is a maculo-papillovesicular rash. And when I say maculo-papillovesicular rash, it's gonna be a presentation of chickenpox even without a clinical history. Question is saying, what is the leading complication, guys? Yes, again, waiting for answers. What is the leading complication of chickenpox? Otitis media is answer for measles, buddy. Ray's syndrome is a rare complication. Rare complication. Ray's is a rare complication. SSP, buddy, is measles. Otitis media is answer for measles. SSP is answer for measles. So it cannot be A and B. You are left between C and D, guys. This is gonna be secondary skin infection. The leading complication of chickenpox is secondary skin infections. That is why lots of time we have to give antibiotics along with this also, guys. Please remember, when do you have Ray's syndrome? When chickenpox patient was taken to a quack. Like government is planning MBBS for 2 years, no? You all know, na, the government of India with their brilliant brains, now they're planning MBBS for 2 years and they will be having diploma doctors. So what these diploma doctors and quacks will do is they can give aspirin to the child. Like, normally for fever we give paracetamol. This diploma doctor, he thinks he's smarter than you. So this guy, he has given aspirin. When you give chickenpox, when you give aspirin in a case of chickenpox, it causes extensive liver damage. It will cause features of hepatic encephalopathy. Blood ammonia levels will be elevated in this baby. This baby will develop features like his liver is damaged because his liver is damaged. This presentation that I have marked out before you, combo of aspirin in chickenpox causing damage to the liver, is called as Ray's syndrome. This is a rare complication of chickenpox. Just like you are aware of the fact that the most common complication of measles is otitis media followed by pneumonia, and a rare complication of measles. Okay, guys, SSP is a complication of measles or measles vaccine? SSPE is a complication of measles, or is SSPE a complication of measles vaccine? Yes, let me just check. No, it's not a complication of vaccine. No, it's not a complication of vaccine. It's a complication of measles. The virus can cross the blood-brain barrier. How do you diagnose SSP, guys? What investigation? What investigation is done for diagnosis of subacute sclerosing panencephalitis, where the virus has gone in the brain and caused damage to the brain of the child? The test that you will do in this case would be a CSF examination. And what will you check in CSF? You will be going in for CSF ELISA for measles antigens. It is CSF ELISA for measles antigen that would be done. Please remember, SSP is not a complication of vaccine. We are giving vaccine because we want to prevent this from happening. So you can see there are two things which you have learned here. One is that you will know about these common complications. Like the PSM guy will scream his lungs out saying leading complication of chickenpox, secondary skin infection. Leading complication of measles is otitis media. When we are given a picture of the rash, you as a doctor should be able to identify whether it is going to be measles or whether it is going to be chickenpox. And that is definitely, something that can come with practice, and by looking at the lesions also. And do remember regarding the rare complications as well. So definitely the answer to this question is delta. This was a repeat from this time, guys. No, not a repeat from this time. I've changed the question. Yes, I've changed this one. A 10-year-old child put finger in the electrical socket and got electrocuted. Whenever a person gets electrocuted, he or she can definitely end up with development of problems. The problems can be in a sense that he can develop arrhythmia. And what's the arrhythmia, guys? Here you can see the twitching of the ventricles. So what is happening here is a ventricular fibrillation. The BP has crashed, and you need to get this kid back to normal. He's saying, what are you gonna do in this, guy? So let's rule out the options, guys. If you look at option number A of this MCQ, it says intravenous adrenaline. Now, intravenous adrenaline is something that you're gonna give in a case of a patient who is actually having cardiac arrest. I'm ruling out option number A of this MCQ. Why? Because of the fact that when it comes to option number A, you need to understand that adrenaline is given in cardiac arrest, and this patient is not having a cardiac arrest. So definitely option number A has been ruled out. Now, when you look at option number B of this MCQ, when you focus on option number B of this question, let me just come back to the slide. Yes. When you come back to the slide, guys, you can see the fact that there is cardioversion also given and defibrillation also given. Now, what is the difference between cardioversion and defibrillation is the core behind this question. You see, we always read DC shock. DC shock is of two varieties. Either we call it synchronized or we call it non-synchronized. Or when will you call it synchronized? You will call it synchronized when the DC shock is delivered with respect to the peak of the R wave. Listen to my words very carefully, guys. Majority of doctors mess up between the word cardioversion and defibrillation. Please appreciate synchronized DC shock is when the computer will deliver the shock at the peak of the R wave. The alternative name for this is going to be called as cardioversion. So what is cardioversion? It is synchronized DC shock. I repeat again, what does synchronized mean? The computer will pick up the peak of the R wave. When you look at non-synchronized means that the impulse of the shock is delivered randomly at any wave of the ECG. It could be PQRST. I mean, because the R wave cannot be seen. Like if you look at this ECG, this is not a normal ECG. The computer cannot identify the R wave because this is only twitching. So the computer will get confused. The technical term that we use for non-synchronized DC shock is defibrillation. So I want you to understand that cardioversion and defibrillation is not the same. Cardioversion is going to be when the peak of the R wave can be identified. But in this arrhythmia, there is no identification of the peak of the R wave. The correct answer to this question is defibrillation. Remember my next statement very, very carefully. Defibrillation is answer to only two MCQs, ventricular fibrillation and pulseless ventricular tachycardia. Only in two multiple choice questions, answer is ventricular fibrillation and / pulseless ventricular tachycardia. These are the only two medical conditions where answer is defibrillation. For all other scenarios, like if he says atrial fibrillation, he says atrial flutter, he says paroxysmal supraventricular tachycardia, whatever be the arrhythmia given in the exam, if you are supposed to answer what kind of DC shock would be given to the patient, your answer will be synchronized. That is, the computer will be able to pick up the peak of the R wave, and the alternative name for synchronized DC shock is cardioversion. If it is random firing, we call it defibrillation. The easier way to correct the question is just remember this slide that I'm mentioning before you. Most of the time, the arrhythmias they're gonna give you are gonna be something like this. Either it's gonna be a flat line, or it's gonna be a twitching like ventricular fibrillation, or it's going to be a ventricular tachycardia. How does a VT look like, guys? Ventricular tachycardia will always be having broad complex QRS. It's always going to be a broad complex QRS. Compare this with the PSVT. Compare with this with the PSVT. Keep your eyes on the board and keep on listening to what I'm saying. In a PSVT, guys, what's going to happen is that you're gonna get a really narrow QRS with a ST depression. And now you can see I've drawn a single wave. This single wave that I'm making before you is due to merging of the P and the T wave. Mark my words there. Merging of the P and the T wave is going to contribute to development of this single abnormal looking wave, which is neither a P, neither a T, because it is formed by merging. Well, what did I draw here? I drew here was in the inferior ECG, I drew a narrow QRS. I also drew here before you a very significant ST segment depression. And you can also see that this is formed by the merging of the P and the T wave. This merging of the P and the T wave will be written in the MCQ as hidden P waves. Whenever in an image-based question in the actual exam, they give you a narrow QRS with a ST depression with hidden P waves, your diagnosis would always be given as paroxysmal supraventricular tachycardia. On the other hand, if it's a broad complex QRS, it is ventricular tachycardia. You can see all of these are of equal size. So I'm gonna call it monomorphic ventricular tachycardia. So Perley is a piece of cake for everybody. Ventricular fibrillation, this is gonna be a piece of cake for everybody. That is gonna be asystole. I'm gonna sketch one more before you look at this one. Here, the QRS complex is varying in amplitude, big, small, random big, random small. You can see the fact that now what is happening is that the QRS complex is a variable size, guys. We are gonna call it a polymorphic ventricular tachycardia. You should be having capability to work out answers for these questions, random fire questions. Now, can you tell me the best drug for preventing PSVT? Yes, guys, I'm just switching to the chat. What drug? Yes, polymorphic VT, guys. Delta is WPW, we're not talking about. Yes, guys, what do we give for prevention? Adenosine for prevention. Come on, guys. Adenosine is for treatment or for prevention? Yes, Bharat got it right. Guys, you need to get answers correct. For prevention, it is verapamil. It is not adenosine. And what is the best way for prevention? The best way for prevention is burning the abnormal electrical circuit. We call it radio frequency ablation. Prevention of PSVT is gonna be RFA. Okay, guys, what do you use for management of ventricular tachycardia after myocardial infarction, post MIVT? Yes, guys, quick answers. I mean, pharma, you've studied, medicine, you've studied. What is the drug that you're gonna use for management of post-MIVT? I had answers coming up. Yes, it's gonna be lignocaine. But if lignocaine is not in the options or post-MI word is not given, then the answer would be given as amiodarone. Guys, lignocaine is a local anesthetic, na? Lignocaine is a local anesthetic. Can you give lignocaine IV? For people answering lignocaine, please tell me, can you give lignocaine IV? No, lignocaine is never given in a blood vessel. It causes cardiac arrest, no? Here I'm saying lignocaine is given. Is there a difference? Is there a difference between lignocaine that is given IV and the lignocaine that is given? Question to you guys. Is there a difference between lignocaine given IV in cardiology versus lignocaine that is given for local anesthesia? Okay, today's UPSC question. Okay, great. Yes, guys. In UPSC, they'll always ask guys questions like these. Yes. Okay, I cracked UPSC exam, guys. Almost I cracked it in my final year. I cracked it in my internship in my first year of PG, second year of PG. Then I got fed up of it. In UPSC exam, no, you get recruitment directly to Indian Railways. You become a medical officer in Indian Railways. Very cushy job, very comfortable job. Or you get recruitment into you get recruitment into this government health sector. Like you can be posted at a primary health center or anywhere else. I got usually I got ranks between 18, then 21, 27. It's long time back, 1999 is when I cleared this UPSC exam, and I got ranks in all of these. And I got railways first time, I got MCD second time, I got CGHS, Central Government Health Scheme, next time. But I did not select it because the life is very comfortable, and comfortable is what I don't like actually. So I would call myself a mutation, so I did not join. Anyway, coming back to the main agenda, guys, is there a difference between lignocaine given intravenously? Is there a difference between lignocaine that is given intravenously in cardiology versus lignocaine that is given as local anesthesia? Because when you would be listening to anesthesia, ma'am, she is always saying, whenever you give local anesthesia of lignocaine, withdraw the plunger of the syringe to see whether the lignocaine is not injected into the blood vessel. The anesthesia teacher and pharmacology teacher will always say, never ever give lignocaine in a blood vessel. Withdraw the plunger to see the needle is not in the blood vessel, because lignocaine should be given locally for local anesthesia. And look at what you guys are telling me, lignocaine given IV. What is the difference? The difference is, guys, there are two different brands. This you should know as doctors. One is xylocaine and second is xylocard. Xylocaine is the one which is used for local anesthesia, and Xylocard is one which is used in cardiology. And the difference between the two is that the one that is having xylocaine will be having combination of two things. It is having lignocaine plus membrane stabilizing effect and a membrane stabilizing agent. This membrane stabilizing agent should never be injected intravenously. I repeat the statement. When you're giving xylocaine to the patient, na, xylocaine is the one which is gonna be lignocaine with a membrane stabilizing agent. This should always be given locally, never inject into blood vessel, otherwise cardiac arrest will occur. But Xylocard can always be given intravenously. Why I'm teaching you this is because tomorrow, after clearing this exam, when you will open your own nursing home, don't forget to invite me when you open your own hospital. I want you all guys to now forget that you are students. You're gonna be future doctors. Think that after 2 years, you have done enough hard work, guys. 4.5 years of medical school is not a joke. If you're listening to me for this long and you are making an effort, my video is not working and still you are listening to me, I want you to understand, think like a businessman, guys. I want you to think you have spent 4.5 years of your life in a medical school. You have spent money on air tickets, etc., etc. So sufficient investment has been done financially and mentally. Now is payback time. You have to develop capability to open your own stuff. I mean, you should be able to independently start your own practice after 2 years. Once you are done with this exam and you're done with everything, you want to do post graduation, I'm very, very happy. But your thought process is, don't think about that I only have to clear an exam. Because when you will think only about, when you will think, yes, 6 long years, yes doctor, I agree to you, in some countries it's 6 and something longer than that also. I definitely agree to you, no doubt. In India it's like 4.5 years. We guys got it a little, a little easier. But my message to you is, my message to you guys is that please do not think that you just have to clear a goddamn exam, because that's a myopic view. That is a short view. You have to think about, you're going to be doctor, man, you're going to be talking to somebody. I'll just say like this: the way you talk, the way you write, the way you explain things, your patient will respect you for that. If you have to earn respect, and respect cannot be bought, right? Respect is to be earned, guys. If you want your patient to respect you, when he looks in your eye, when the patient looks in your eye, and remember these words of mine for the rest of your career, if you want the patient to have that look in his eyes of gratitude and thankfulness, you need knowledge. Because as I say every time in my routine class, no, knowledge is power, knowledge is power. A lot of guys ping me, sir, what the hell is knowledge is power? Knowledge of power is, guys, that you earn respect with that. Because if you see a patient who's eyeballing you, something is wrong. Maybe you talk to him the wrong way, or he does not think you are capable enough. A lot of medical legal cases in India nowadays are happening primarily because of the fact that either we doctors do not have good communication skills or we have lack of knowledge. Let's be honest, put our hand on our heart and say, put our hand on our heart and say this fact that, you see, I am not perfect. Because it requires guts, man. It requires guts to say I am not perfect. First and the foremost thing that I want you guys to understand as doctors is, put your hand on your heart and say, yes, I have lack of this knowledge, I want to learn it. Because that is the first thing, humility. And the next step that you will go ahead will be the yeah, sir, I understand. You see, docs, it is not the case. Sonu, I'll tell you a case. Just today there is one student of mine from Ukraine, and he's running a orthopedic hospital in Jalandhar. He messaged me today. His OPD is at least of 50 people, and he's doing THR. He's exclusively doing THR and TKR. He has I remember forgot the city from which he is, but he's in my yeah, they discriminate doctor. I understand that, but that will go away very soon. No? Once this common exam will come, the discrimination part will go away. I agree to that, right? So what I am trying to tell you is, guys, you need to, you see, it's every man for himself. You have to fight for yourself, man. I mean, fight for yourself. What I mean is that, this guy, he was as nervous as you guys are today. If I go back, I was just starting with him, and like he says, sir, 6 7 years ago, when he was a young guy like you, or a young chap like you, he was as nervous as you guys, and he was wondering about how his career will be. And then he put in his hard work. He cleared the exam, not in the first, but in the second attempt. Then he got into orthopedics, and then he went into specialization for joint replacement. And he's running an excellent practice. I mean, he has put everybody back, because foreign medical graduates have very, very good business sense. Even MBBS won't be able to score 150. Yeah, doc, I agree. You see, Kaushal, I have explained. Get over that, buddy. Kausar, if we will continue with that thought process, no, if we will continue, we will not be able to grow. Whatever ab hona to ho gaya na. Like I agree to the fact they were trying to, take revenge on us and everything. But the point is, whatever has happened has happened. Now you need to look at what is going to happen subsequently. So I agree to that. Trying to be good. Let's be positive, guys. Let's spread positivity. Let's gonna be rocking the scenario. I want you guys to have that attitude. Yes, I'm gonna do it, because you see, I'll be very very critical here to you. If you are circulating in a group with a guy who's always with a friend, a friend of yours can be very good friend, but some people are negative people, they'll always talk negative. Then what will happen is that the negative vibes start coming in you slowly. So thoda, your mind is like a sponge. Today I told you two things. Mind is like a little baby, it will run away, make it come back, study again, right? That is one. And the second thing is, guys, the second thing is that we need to be very very positive in our attitude and approach, guys. Because this what I'm saying, like xylocaine, lignocaine. If you mess up between xylocaine, suppose you are not messing up, your nurse is messing up. If they're giving us lemonade, let's make a lemonade out of it. Okay, fine. God, that's a good pun. Okay. Hi, take care. We will rock. We will rock. Okay. Guys, what I'm trying to say is, like, suppose your nurse, let's talk about medical legal issues here, right? Suppose your nurse will change the vial. Like, suppose your nurse, she has changed the vial and she has placed lignocaine, xylocaine in place of xylocard and vice versa. Medical legal complications can definitely occur. So it is our responsibility to ensure that this does not happen. Coming back to the agenda, guys, ventricular fibrillation, the main treatment that we're going to do is to give a DC shock. This is going to be non-synchronized DC shock. And remember my words, the alternative term for non-synchronized DC shock is that it's going to be a defibrillator, right? But if it is going to be ventricular tachycardia, it's again going to be defibrillator, but for PSVT. If he says in the exam, listen to the words carefully. I know you guys are tired. If a PSVT patient is having unrecordable BP, what will you do? You will go in for a synchronized DC shock. The computer will read the R wave and deliver this R wave. Computer will read the R wave and deliver the DC shock. This is what is called as cardioversion. So please, on a piece of paper, write either of the two things. Write down what is cardioversion, what is defibrillation, because that concept has to be clear to you, because you are the one who's going to be giving orders, right? When it comes to asystole in a person, this was asked this time, guys. We do not give DC shock. DC shock is contraindicated in a flatline ECG. To restart the heart, what will you give? You will give adrenaline to the patient in 1:10,000 dilution. So please appreciate the fact that in television serials, they will show DC shock being given in flatline ECG. I have highlighted that already to you guys. You very well are aware of what I always say. Television serial is not a reality. Tachyarrhythmias is something, arrhythmias is something in ECG. That's the basic skill that you should be able to crack. So I'll just do a few more and we are done for today. And let's look at another question. Let's rush through, guys, quickly. Okay, moving to the next one. Great, great. No, doc, they will not. Yeah, doc, I'll just show the previous slide. I'll share this in, I'll share this. Okay, I'll just put my email ID here, and you guys can just send me a mail at marwahmedicine@gmail.com, and I will be sharing this slide to you if in case you want it, right? Or you can just take a snapshot of it. My email ID is marwahmedicine@gmail.com, so you can just send me a mail at this and I'll send you a snapshot of this. But yeah, doc, doctor, iPad is written. Yeah, I'm coming to the next question, guys. Basic point is, guys, most of the questions are very straightforward. This is again a repeat COVID video for medicine in the app. Doc, it will come. COVID treatment is changing, no? So we'll gonna introduce it in towards the end, towards maybe the last week of November. It will be 1 hour video only on the treatment. So we'll definitely put it up. Yes, video on radio. Yeah. Doc, I'm doing it regularly. No, I do put up. If you can go to my YouTube channel, FMG Solutions. I am putting these 5566 questions on a regular. Doc, I know that score, no, 150, 160 is coming. I know it's very sad, and that causes a lot of heartburn. That is the worst thing. Getting stuck at 148, 147 is the big ego crusher. And who's the most happiest? Relatives. The relatives will always be then asking the parents again and again that yeah, sure, doc, I'll be so happy, Sonu, that when you share the good news with me, relatives are so happy. So you see, there are so many reasons for you to study. You see, there are so many reasons for you to study. The reasons for you to study is you want to show it to your relatives, you want to prove it to yourself, you want to prove. YouTube channel is FMG Solutions, dog. FMG, you just type FMG Solutions, and there I conduct YouTube sessions. I just started them, and the FMG Solution name only is there, doctor. FMG Solution name only is there. What about the option D in the last question? Okay, secure airway. See, doc, in a patient of for the doctor who asks for secure airway, doctor, now we don't do ABC. We don't do ABC. MCI Gurukul bothering. Acha, yeah, that is a very personal issue, na. Very difficult to say. Okay. PG IMS is also there. Okay, fine. Yeah, dog. Yeah, you see, guys, we need to have positivity. I'll come back to the agenda. One doctor had raised this query that why answer in 15 is not D. You see, nowadays the resuscitation protocol is not ABC, na. It is not ABC. It is CAB, na. So I think it is gonna be, sir, FMG solution book नया edition लेके क्या करोगे, sir? New edition will come. You will not have time to read it, na. We coming up with the supplement. That salt paper will come. मैंने question का photo दिखाया, lot of people were answering. So main book is not. I mean, I can release a book. That's not an issue. It will not be used. Next question says a 4-year-old child is having fever and poor appetite for 3 days, and then you can see a rash. Right, the rash is gonna be present on the hard pellet, on the hands, on the feet. That is gonna be hand, foot, and mouth disease. Yeah, doc. We are doing clinical only. Hand, foot, and mouth disease. Yes, guys, which organism is responsible for this one? The correct answer is Coxsackie A. Pretty straightforward. That's a relatively easy question for today. Let's move to the next one. The next question says, okay, I'll not take chats now. I'll be rather just focusing on the questions. We are having a 12-year-old kid. He's having daily morning headaches for last 6 months. Whenever you read about daily morning headaches, you are going to think in terms of raised ICP. And another point in favor of raised ICP is projectile vomiting. So two things are telling me that there is raised intracranial pressure in this patient. The child is having difficulty in copying classwork from the school board. Head scan shows a suprasellar mass. You can see the suprasellar mass here in the area of the pituitary. So you can make the diagnosis of this kid very straightforward. This is gonna be a craniopharyngioma. Why is it not option number A, cerebellar astrocytoma? If I zoom in the image, cerebellum is here. You see, this is the cerebellum posteriorly. So this is not a tumor of the cerebellum. Meningioma should be located somewhat here. I'll use a different color. This is the location of the meningioma. It arises from the meninges. So meningioma will always be situated towards the periphery. It will originate from the meninges. So that is why option number B is ruled out. Medulloblastoma. Medulla is here, no? This is the medulla. This is the medulla. This is the pons. And this bird-like structure, no? This is the midbrain. This is the pons. This is the medulla. You can see the brainstem present here, right? This structure which is present here, this structure that is present here is the midbrain of the patient. What is present posterior to this? When you go a little posteriorly, right? This area. This is gonna be the fourth ventricle. And then you can see the cerebellum, which is posteriorly located. You can see a tumor which is anteriorly, and this tumor will also be contributing to a visual field defect. The visual defect in this condition is bitemporal hemianopia. And because of this bitemporal hemianopia in a patient, that is why the child is having difficulty in copying from a classwork. The correct answer to this question is going to be option number D, craniopharyngioma, supratentorial tumor. Can be picked up, because it shows a calcified mass present in the area of the pituitary. Let's look at the next one. This is a kid from rural India. You can see his only skin and bone. So the kid is suffering from marasmus. He's not having kwashiorkor, he's having marasmus. He's saying which is not a clinical feature. So sometimes not can be missed. Loss of scalp hair. Yes, you can see loss of scalp hair. Loss of buccal pad of fat. Well, buccal pad of fat is usually not lost in marasmus. So this may be the answer. Let's read C. Atrophy of muscles. Yeah, you can see mid-arm circumference is reduced. Absence of pedal edema. Definitely yes, because marasmus does not have pedal edema. Kwashiorkor has edema. You are all aware of the fact that in marasmus, the pad of fat is not lost. The buccal pad of fat is preserved. And because the buccal pad of fat is preserved in this condition, that is why we are usually going to read about old man appearance is a facial appearance of a patient who's suffering from marasmus. Question for you guys, which condition have I taught